Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is maternal sepsis, recent concepts as recent as in 2024, and we will approach the topic with question or answer format. How do you define maternal sepsis? Now, it is important to know about maternal sepsis as it accounts for 10% of maternal deaths globally. And when we try to define it, there are two definitions which are quite similar. One is proposed by WHO in 2017, which says that maternal sepsis is life-threatening organ dysfunction because of infection, which occurs in pregnancy, childbirth, post-abortion, or postpartum. So this just focus here that only infection is not sepsis, but whenever infection is associated with life-threatening organ dysfunction, then only we call it as a case of maternal sepsis. Even there is a definition which is given by Third International Consensus Definition of Sepsis, which was proposed in 2016, and this is called as sepsis 3 because it was a third international consensus which provided us with guidelines as well as with the definition. And whenever I will be using this sepsis 3, then it means that it is as per the third international consensus definition. Now this consensus defines sepsis as life-threatening organ dysfunction caused by dysregulated host response to infection. And again, that will be also be in pregnancy, childbirth, post-abortion or postpartum. So if we see the definition, infection, and if there is a regulated host response, it leads to clearance of infection. On the other hand, with the onset of infection, especially during pregnancy, childbirth, or post-abortion, postpartum, if there is a dysregulated host response, then it leads to life-threatening organ dysfunction. And whenever there is a life-threatening organ dysfunction along with underlying infection, then we define it as then we call it as a case of maternal sepsis. An obstetrician should consider sepsis in each case of infection is the most important uh, guideline. So many guidelines, especially RCOG guideline, Green Top guideline of UK, as well as American guideline, they are mainly stressing on this point only that we should consider sepsis in each case of infection. In other words, we should be always vigilant to see whether there is any organ dysfunction associated with infection. Any organ dysfunction, you immediately diagnose it as a case of maternal sepsis and start aggressively managing the case. That will reduce the maternal mortality because of maternal sepsis. Early diagnosis definitely prevents death. And that is why we need to be now, whenever you are sitting in the OPD or we are examining any patient in early pregnancy, we say that we should all be having our we should all be vigilant about the detection of ectopic pregnancy. That is the dictum mainly for the first trimester early pregnancy patient evaluation, because it so in your career so many times you will get a surprise and you are likely to miss a case of ectopic pregnancy if you do not remain ectopic conscious. Similarly, for sepsis also, we need to be extra vigilant because infections are common, but every infection is not sepsis. But early detection of organ dysfunction improves the prognosis, and that is the reason we all should be, any patient who is coming to us with infection, we should always be looking for the features of organ dysfunction to identify whether she is a case of maternal sepsis. Now, next terminology is septic shock. So, what is septic shock? It is the sepsis with circulatory, cellular, and metabolic dysfunction. So whenever there is a maternal sepsis associated with either circulatory dysfunction, that means there is a fall in blood pressure, tachycardia, uh, decreased in the uh, intravascular compartment, hypovolemia, or there is a cellular dysfunction, or that means either the cellular dysfunction might be at various organs. It can be at liver, kidney, lungs, or metabolic dysfunction, such as there can be acidosis, there can be increase in the lactate level. So if it is a sepsis is associated with any of these, then it is called as a case of defined, it is diagnosed as a case of septic shock. So criteria to diagnose septic shock. Now the name suggests that it is a shock. That means there has to be a fall in blood pressure. But the latest concept differs. As per the latest concept, specially given by our sepsis 3, hypotension, when do you say it is a case of septic shock? Whenever there is a maternal sepsis along with hypotension, which requires vasopressors to maintain mean arterial pressure of 65 millimeters of mercury. MAP 65 millimeters of mercury. MAP, as you know, systolic blood pressure plus twice diastolic divided by 3. I hope you all are aware about the formula to calculate mean arterial pressure. Again, I am repeating, systolic blood pressure plus twice diastolic. This sum of these two is divided by 3. That gives us the mean arterial pressure. And our aim is to maintain the mean arterial pressure around 65 millimeters of mercury. And if in spite of if hypotension needs vasopressors, in spite of giving IV fluids, also there is a persistence of hypotension, and you need to start vasopressors, then you diagnose it as a case of septic shock. And or what is more important is, if even if there is no hypotension, but if there is an increase in serum lactate levels greater than 18 milligram per dl or greater than 2 millimoles per liter in spite of IV fluids, then also it is defined as a case of diagnosed as a case of septic shock. So though it is septic shock and patient is normotensive, and with a normotensive woman, see, you are monitoring the patient with serum lactate level and there is an increase in serum lactate, it is sufficient to diagnose it as a case of septic shock. Is the most latest recent advance related to the topic of maternal sepsis. That septic shock is there does not necessarily always be because of fall in blood pressure. It can be with a acidosis also, metabolic dysfunction also, and that metabolic dysfunction we diagnose it by doing serum lactate levels. So what is the new concept is hypotension is not mandatory to diagnose septic shock. Tissue hypoperfusion precedes hypotension. Before there is a fall in blood pressure, all the tissues in the body are getting hypoperfused. That means the blood supply to the tissue is getting affected, it is reduced. So tissue hypoperfusion precedes hypotension, and serum lactate is a marker of tissue perfusion. So whenever there will be tissue hypoperfusion, what will happen is there will be increase in serum lactate. Serum lactate clearance will be will reduce with a hypoperfusion, and that is the reason serum lactate is a marker of tissue perfusion. And rising serum lactate level is sufficient to diagnose a case or a level greater than 2 millimole per liter or 18 milligram per dl is sufficient to diagnose a case as a case of septic shock. Now, severe sepsis terminology is no more being used as per this sepsis 3. So, we are using only two terminologies now, sepsis and septic shock. Previously, in between the sepsis and the septic shock, there was one entity which was identified as severe sepsis, but that adds to the confusion, and that is the reason, according to these newer guidelines, since 2000 we have a 2024 guideline, this RCOG, and American Association of Family Physician 2020 guideline. All these guidelines are now telling us that this severe sepsis terminology should not be used. What we understand is the category of the disease is only two categories. One is sepsis and second is septic shock. So to revise the definition, if patient has infection, for example, patient has urinary tract infection, and then there is a organ dysfunction which is life threatening. Patient has severe UTI which remains untreated for a long time, and now she is coming to you with, say, organ dysfunction in the form of affection of either lungs, kidneys, or there is a infection which is spreading to kidney, leading to pyelonephritis, and then it is even affecting the liver, all, or brain also. Then in that case, life-threatening organ dysfunction is there along with this underlying infection, pre-existing infection with organ dysfunction. Then we define that patient or that condition as a case of maternal sepsis. With maternal sepsis, if there is a tissue perfusion or hypotension. Tissue perfusion precedes hypotension. So even if there is only hypoperfusion, tissue hypoperfusion, then also it is a case of septic shock, or there is a hypotension, then also it is a case of septic shock. Hypotension which is requiring vasopressors. That is the requirement to complete the definition of septic shock, that any hypotension which necessitates the use of vasopressors. Or for this tissue hypoperfusion, if serum lactate level is greater than 2 millimole per liter, it is earlier feature. That is why I have given it a star. Hypoperfusion occurs earlier, and then it is followed by fall in blood pressure or hypotension. Terminologies which are not used now are, by according to sepsis 3 are SIRS. SIRS is systemic inflammatory response syndrome. This terminology was quite commonly used by even general physicians also whenever there was any sepsis, but this is no longer is being used as per the latest recommendations or guidelines. And second terminology which is no longer being used is severe sepsis. So we have only two categories now, sepsis and septic shock. How to identify life-threatening organ dysfunction to diagnose sepsis in clinical practice. Now we have seen that definition of maternal sepsis is presence of infection along with organ dysfunction. So how we will know there is an organ dysfunction? For that we have some certain criteria. First criteria which was being used quite commonly in the past is SIRS criteria. SIRS, as I said, is systemic inflammatory response syndrome. SIRS criteria to diagnose sepsis. As per this criteria, there should be at least two of these four features to diagnose a case as a case of maternal sepsis. First is patient should have fever greater than 100.4 degrees Fahrenheit, tachycardia with a pulse rate greater than 90 per minute, respiratory rate should be greater than 20 per minute, WBC count greater than 12,000 or less than 4,000 per microliter, or greater than 10% immature forms, any of these, one of these three. And if out of all these four features, any two features patient is fulfilling, then according to SIRS criteria, we diagnose it as a case of maternal sepsis. Now, why it is no longer considered by sepsis 3 is its sensitivity to diagnose sepsis is low, 50%. That means even if the patient has sepsis, two features you might not get in as high as 50% of the patients. You are likely to miss the diagnosis. And it is also present in non-infectious conditions also. So it is not specific for sepsis only. So many times we get tachycardia, we do get this tachypnea, and change in the WBC count, a raised WBC count during pregnancy is very common, and that is how we are likely to have a false positive diagnosis of maternal sepsis if we follow this SIRS criteria. But still, it at present it helps to diagnose acute infection, and that is why it is still being used in the clinical practice. And American guidelines says that we should not be completely discarding it, as it might help us to detect acute infection in some patients. So our age-old TPR, temperature, pulse, respiration, you can remember it like that, TPR with WBC count. Now, what is the new criteria to diagnose sepsis? Whenever there is a suspected sepsis in a patient who comes to us with infection, any infection. Now, as I have given the example of urinary tract infection, sometimes there can be patient can have a respiratory tract infection, pneumonia can be there, or sometimes patient can have a unrelated infection, such as there can be some skin lesion or abscess, any infection, or even I have seen patient of a breast abscess going for mortality with a development of a septic shock. Very unfortunate, but any infection during pregnancy can proceed to this sepsis, and it can then, if remains untreated, neglected, can go for a septic shock also. So whenever there is an infection and there is a suspected sepsis in a non-ICU setting, what we have to follow is this Q-SOFA criteria. Quick SOFA, sequential organ failure assessment. SOFA is, Q is for quick, it is bedside, so there is no need to go for any elaborate laboratory investigations, and that is why it is called as a quick sequential organ failure assessment criteria, Q SOFA. And we should also be using this SIRS as per the American guideline till we get better criteria to diagnose sepsis, that is systemic inflammatory response syndrome criteria, which we have already seen in the previous slide. But if patient is already in ICU or patient's condition is bad and needs ICU admission, in that case the criteria which is used is called as SOFA score, that is sequential organ failure assessment score. So according to the new recommendation, SIRS is not recommended by this sepsis 3, that is the third consensus, sepsis consensus definition, or consensus conference. It is mainly advocating Q SOFA in a non-ICU setting and SOFA in a ICU setting to diagnose sepsis. What is Q-SOFA criteria to diagnose sepsis? Q-SOFA is quick sequential organ failure assessment criteria. Again, we need two, but out of three, we need two. Here, the three criteria which are given by Q-SOFA are patient having tachypnea, respiratory rate greater than or equal to 22 per minute. It was 20 per minute in SIRS. Here, it is 22 per minute. Altered mental status, GCA is Glasgow Coma Scale. If it is less than 15, that indicates altered mental state. And third is systolic blood pressure greater than or less than or equal to 100 millimeters of mercury. Out of these three, any two is necessary to diagnose the patient as having a significant organ dysfunction in a pre-existing scenario of infection, to diagnose the patient as a case of maternal sepsis. Now, what are the limitations of this Q SOFA? It also has low sensitivity to diagnose sepsis, same as SIRS, 50%. Now, it might lead to late diagnosis of sepsis. There is a possibility of a delayed diagnosis. If you look at the criteria, you will understand that there is already we are going to diagnose sepsis whenever there is a involvement of brain, or already there is a hypotension, or there is a significant tachypnea. Out of these three, we need two. That means by that time, the sepsis has already gone to a stage of a late stage of the disease, and that is the limitation of this Q so far, that though it is specific, it leads to a late diagnosis of sepsis. Advantages are, there is no need of any laboratory, as in SIRS we need WBC count, it is not required. No need of lab investigations for Q SOFA. It is bedside assessment, and it can be, that is why it can be administered rapidly. Q-SOFA and SIRS both are in combination to be used in clinical practice for early diagnosis of sepsis as per American Association of Family Physicians 2020 guideline. And I also do believe that in clinical practice, still, though the latest concept is we should not be going by SIRS criteria, I do believe that it helps us to diagnose acute infections where we can remain vigilant for the development of organ dysfunction, and we can remain vigilant to diagnose maternal sepsis. And Q-SOFA will help us for a specifically to identify the cases where there is a strong possibility of sepsis which needs immediate attention, and if not treated, patient can very fast go for a septic. What is Glasgow Coma Scale? It is a clinical neurological assessment, and why I have included it is so it is again clinical. It doesn't need a elaborate setup. It is very easy, and as obstetricians, we should be aware of this because it helps us to quickly assess the neurological status of the patient. And even in hemorrhagic shock, it is not only for septic shock. Even in hemorrhagic shock, also it helps us a lot because always we say that you talk to patient whenever you face any complication in clinical practice. Keep on having a dialogue with the patient because then only you understand whether patient is alert or not, whether she is getting confused, or whether inappropriate response is there, or whether she is not able to articulate her thoughts and her speech is incomprehensible, and if there is no response, it is bad. So this verbal response is one of the way of knowing going for a neurological assessment. And any hypoxia, severe hypoxia, quickest way to diagnose it clinically is talk with the patient, and you will understand that there is a something is definitely wrong, and it is severe affection of the brain whenever there is a decrease in the verbal response. And the uh, higher score indicates that patient is not having any risk of any involvement of the brain. But as you proceed down, the score reduces as the low scoring is associated with abnormal neurological condition of the patient. Then now, how is the eye opening? Whether patient can open eyes, spontaneously opening the eyes, or only to our verbal command, or to pain only. And if there is no response, the score of 1. Motor response, whether patient can obey or is obeying the commands, she can localize the pain, or if we are pinching her and she withdraws from pain but not able to localize or not obeying the commands, whether there is abnormal flexion or abnormal extension, her posture also, and no response. So all this together you calculate, and if any time this Glasgow Coma Scale is less than 15, it is abnormal. It is as indicative of a uh, affected mental condition, which is very important feature of shock. And in this quick SOFA criteria, one of the criteria is to assess the mental status of the patient. So what is the difference in Q-SOFA and SIRS criteria? If you are asked to diagnose sepsis, what is the difference? Q-SOFA, you need any 2 out of 3 criteria. SIRS, you need 2 out of 4 criteria. Here, the respiratory rate is on both the in present in both. Here it is greater than, it should be greater than 20. Here it is greater than or equal to 22. Slight difference, but respiratory rate is common for these two. What differs is fever, pulse rate, WBC abnormality is there in SIRS. All these are not there in Q-SOFA. Q-SOFA, altered mental status and systolic blood pressure less than or equal to 100 mmHg. Q-SOFA is only clinical, so it is quick, whereas SIRS needs especially complete blood count, and we need the WBC count to diagnose the presence of sepsis as per SIRS criteria. Both sensitivity of both these is around 50%, but Q-SOFA is more specific, whereas SIRS is less specific. So many conditions we can have increase in the pulse rate, increase in the respiratory rate, especially during pregnancy, without patient be having any sepsis also. But it helps more in the detection of acute infections, whereas here Q-SOFA is more specific, but it is diagnosing sepsis at a late stage. That is a disadvantage of this Q-SOFA criteria. I hope this becomes clear. And my request to all the clinicians and even postgraduate students is you should be using both these criteria whenever a woman comes to you and you diagnose in pregnancy, post delivery, post abortion, whenever there is a patient has fever, or whenever you are suspecting presence of infective focus, always apply these criteria so that it will help you to objectively diagnose a case of maternal sepsis. These are very, very important. These both should be at tip of the tongue for all the obstetricians. Now, what is SOFA score related to sepsis? Sequential organ failure assessment score. Q SOFA is in clinical non-ICU setup, whereas SOFA score is used mainly in ICU setup, intensive care unit setup. It is a mortality prediction score. Mortality risk increases with the increase in the score. That is how it helps in counseling. Whenever we are counseling the relatives, it helps us a lot to mainly counsel the relatives related to the possibility of having a recovery or how is the prognosis. It assesses degree of dysfunction of 6 organ systems as score of 0 to +4. 6 organ systems are respiratory system, as you can do it, assess it by going for a partial pressure of the oxygen in the blood. It needs blood gas analysis, and that is why it is we say that SOFA score is only for ICU setup. It needs blood gas analysis. Then coagulation system is the second organ system, and platelet count, if it is normal, greater than or equal to 1.5 lakhs, then score of 0. That is one example I have shown deliberately. Otherwise, there is this score should be in the ICU. It should be on a at the on a wall so that it should be available very easily so that we can calculate it quickly in the ICU. And if platelet count is less than 20,000, then the score of +4 is given. That is how for every system it is like that, from 0 to +4. Glasgow Coma scale for the assessment of brain, for circulatory system, blood pressure and need of vasopressors, that gives us the score. Serum bilirubin level for liver function and serum creatinine level for renal function. So these are the 6 systems: kidney, liver, circulatory system, brain, coagulation system and respiratory system. Now this SOFA score should be measured on admission to the ICU first, and then it should be measured every 24 hours so that it tells us the whether the how is the patient's condition, whether it is improving or whether it is worsening, and mainly it helps for mortality prediction. Greater is the score, more is the risk of mortality. Now coming to what are the risk factors for maternal sepsis. So we can divide the risk factors into maternal risk factors and obstetric risk factors. In maternal risk factors, elderly patient, obesity, diabetes, anemia. I have seen so many cases of anemia. With anemia, there is a reduction in our body's defense mechanism, and immune system is weak. And I have seen severe anemia, patients dying either of hemorrhage or sepsis. I have seen both the scenarios, and uncorrected anemia in pregnancy, unfortunately, is the main underlying condition which leads to maternal mortality, not as a direct cause but as an indirect cause. Anemia with hemorrhage, anemia with sepsis. Patient is progressing very fast to septic shock with a severe anemia. Immunocompromised woman, prior pelvic infection, contact with invasive group A beta hemolytic streptococcus. GAS is group A streptococcus, and if the patient has got a contact with invasive group A beta hemolytic streptococcus infection, there is high risk of going for pneumonia. And, that is why it is considered as a risk factor. Any underlying liver disease, renal disease, or cardiac disease. In the obstetric risk factors, we have prolonged rupture of membranes, cesarean section itself is a risk factor, vaginal trauma in a vaginal delivery, retained products of conception, especially with after delivery or in a case of abortion, multiple gestation, amniocentesis or any invasive procedure during pregnancy, and cervical cerclage. So these are the risk factors for development of maternal sepsis. Now, what are the infections in pregnancy which can lead to maternal sepsis? Commonly encountered infection. So, first is pyelonephritis. Pyelonephritis is one of the common cause of woman going for a septic shock. That is why it is at the top. Septic shock and septic shock. Whenever there is a septic shock, chances of maternal mortality are very high. Chorioamnionitis, puerperal sepsis, pneumonia, septic abortion, and necrotizing fasciitis. Necrotizing fasciitis is a bacterial infection of the wound causing tissue death and sepsis. I have seen only one case of this necrotizing fasciitis in my career, but it was very difficult to control that. She needed repeated debridement, but fortunately, we could save the patient by giving broad spectrum antibiotics and aggressively going for the debridement. But really, it leads to the tissue death in the surrounding tissue. It goes deeper and deeper. It burrows like that, necrotizing fasciitis, and the wound is usually pouring pus. And even if you try to clean it in the evening, again you will find that it is full of pus. So it is a very fast progressing type of a skin infection, bacterial infection, especially over the wound. And I have seen it in one patient only, but that was really frightening experience. So necrotizing fasciitis also can lead to maternal sepsis. Puerperal sepsis I have seen. Even I have seen death because of puerperal sepsis. Septic abortion leading to mortality I have seen. Going for a septic shock and necrotizing fasciitis I have seen. I have not seen pneumonia leading to maternal death, but pneumonia can be uh, one of the cause where there can be a beta this group A beta hemolytic streptococcal infection, and patient can very fast progress to septic shock also. Now, what are the common organisms leading to maternal sepsis? You can divide it into gram negative, gram positive, and anaerobes are also there. Aerobes and anaerobes. In gram negative bacteria, most common is E. coli, Escherichia coli. In 40% of the cases of puerperal sepsis, the infection is because of E. coli. And especially this E. coli infection is found more commonly if patient presents with urinary tract infection or preterm pre-labor rupture of membranes, or in a case of cerclage. Other gram negatives such as Klebsiella are responsible for 4% of the cases of maternal sepsis. In gram positive beta hemolytic streptococcus, group B streptococcus, GBS, it leads to maternal sepsis in 20%. And this organism is present in the vagina. It can affect the mother with chorioamnionitis, and it is one of the common cause of neonatal infection. And that is why GBS prophylaxis is being recommended in the newer guidelines now. Group A streptococcus leads to respiratory infection in around 4% of the cases of this maternal sepsis. Staphylococcus aureus infection is responsible for 7% around. This one study has given this split um, as most common being E. coli and then the rest of the organisms. If there is a wound infection which is not responding to usual antibiotics, we must suspect MRSA, methicillin resistant Staphylococcus aureus, which is a rare infection, and it is an indication that there is a need to improve aseptic care in our setup. MRSA indicates that our uh, health personnel are to be re-educated, and we need to even conduct more and more drills, mainly to improve our aseptic care. Anaerobes are responsible for 8% of the cases of maternal sepsis, and what is most important is mixed infections are common. Aerobic with anaerobic, gram positive, negative, and anaerobic mixed infections are common. So any organism, it leads to inflammatory response. There is a cytokine release. Cytokine has got a endocrine, paracrine, apocrine function, which is leading to tissue damage. Rarely there can be fungal, viral, or parasitic infections. I have seen a maternal mortality with dengue infection also. Now, what is coming to the management? What is the first step in the management of suspected sepsis? Now, whenever there is an infection and we are suspecting sepsis, we will be going for QSOFA and SIRS criteria. Anytime it is less than 2, we continue monitoring. And if there is any status change, then we have to initiate sepsis bundle. If there is a SIRS criteria greater than or equal to 2 or Q SOFA greater than or equal to 2, fulfilling it, that means we can diagnose it as a case of maternal sepsis and we need to initiate sepsis bundle. Even if this Q SOFA or SIRS criteria is not getting fulfilled, but there is a increase in the pulse rate by greater than 30, fall in blood pressure to over the baseline to greater than 30 mmHg, urine output is reducing to less than 0.5 ml per kg per hour, or serum lactate is increasing to greater than 2 millimole per liter. In all these situations, we need to initiate sepsis bundle. We do not have to then wait for the fulfillment of QSOFA or SIRS. QSOFA might not be getting fulfilled with the two criteria. Only one might be there. But still, with that, say patient is having tachypnea. But with that, what you find is there is also fall in the urine output, or there is a change like that, or the sudden increase in the pulse rate, then also we should diagnose it as a case of sepsis and we should initiate sepsis bundle. So that is the first step in suspected sepsis is we are trying to diagnose whether it is a case of sepsis or whether it is only infection. What will be the 0 hour management in a diagnosed case of sepsis? Suppose we have diagnosed sepsis with the help of QSOFA or SIRS or status change. What should be the 0 hour management? We need to activate institutional protocol for management of sepsis. In other words, at each health facility, we need to have a sepsis protocol, maternal sepsis protocol. It has been seen by studies, proven by studies, that having a protocol and following rigidly that protocol improves the prognosis and reduces the mortality because of maternal sepsis. First thing is we have to attach cardiorespiratory monitor after hospitalizing the patient with as a case of maternal sepsis. We need to establish 2 IV lines with wide bore needles. Adequate oxygenation is to be ensured, otherwise if we need to start oxygen supplementation also, and we need to consult a senior person. Always involve a senior person, because we know that this the maternal sepsis very fast or in a subtle manner can proceed to septic shock, and then it will be too late. In spite of treatment also, sometimes we are likely to face a maternal mortality. I have seen a case of death, as I have said, in a case of breast abscess, and that was so shocking. that a case of breast sepsis can progress so fast to septic shock, and patient going for mortality was really shocking for all of us. And that is the reason we need to involve a senior person whenever we diagnose a case as a case of maternal sepsis, and we need to initiate the sepsis bundle. Now we are using this terminology again and again, sepsis bundle. So what is sepsis bundle? What is exactly a bundle? You must have heard we are having a PPH bundle. We are having eclampsia bundle. Similarly, we are having a sepsis bundle. So why we are using this terminology as bundle is it indicates that we need to have group of interventions. We need to initiate a group of interventions. It is not only single intervention, but a group of interventions are to be initiated, and all these interventions are to be completed in a specific time. That is why it is called as a bundle. That it is we have to act swiftly. We have to initiate so many multitasking has needs to be done. We need to have multiple personnel also to simultaneously provide all these interventions in a stipulated time. Then only we can hope for a better outcome in all these emergency situations, and that is why there is emergence of these various bundles in emergency obstetrics. So sepsis bundle, it has four pronged approach. First is aggressive fluid resuscitation, where we need to give bolus of crystalloid, mainly ringer lactate, with 30 ml per kg. That much to be given in first 3 hours. Then simultaneously we need to assess for severity of the sepsis by applying SOFA criteria. Laboratory monitoring needs to be done, such as lactate, serum lactate monitoring is most important, to be done every 4 to 6 hourly. Source of infection control is third prong of this subsepsis bundle. And for the infection source of how we control the source of infection is by taking cultures, if necessary by going for imaging, and if the condition requires, then even to go for a surgical opinion also. Antibiotics are to be given once we obtain the culture samples. So this is a four-pronged approach, and that is why it is called as a sepsis bundle, where we initiate the interventions simultaneously. It is not that first fluid resuscitation, you wait for 1 hour, then you go for SOFA, then again another 1 hour. No, this is supposed to be simultaneously. These interventions are being provided. Sepsis bundle to be completed within 3 hours of presentation. Use of bundle and use of sepsis protocol reduces mortality. So that is again pictorially, I want to stress that it is not one by one, but simultaneous interventions in sepsis bundle to be completed in 3 hours. First 3 hours management. Fluid resuscitation, assessment of the condition clinically by SOFA and with the help of lab investigations. For source control, we take cultures. If necessary, we go for imaging and surgical opinion. Also, we opted for the source culture. Any abscess we would like to go for a immediate incision and drainage of the abscess, for example. So surgical intervention, whether it is necessary, that is also to be done. And once we obtain the cultures, we go for immediately we should be starting. So many guidelines say within 1 hour antibiotics are to be started to improve the prognosis in a case of sepsis. We are not waiting for the culture report. We are obtaining cultures and starting the antibiotics. What are the laboratory tests you will advise in a case of maternal sepsis? Complete blood count with differential. Serum lactate is a biomarker of tissue perfusion. It needs to be repeated every 4 to 6 hourly. Anytime it is greater than 18 milligram per dl or greater than 2 millimole per liter is suggestive of a septic shock. Serum procalcitonin is a marker of inflammation. Less than 0.05 nanogram per ml is normal, and as the level increases, it indicates increasing severity of inflammation, and that is why this is also important. Now, the serum lactate, serum procalcitonin are called as sepsis biomarkers. If you are asked What are the sepsis biomarkers? Your answer should be serum lactate and serum procalcitonin. KFT, LFT coagulation studies, urine analysis, arterial or venous blood gas analysis, and blood culture to be sent for aerobic as well as anaerobic. Two separate samples, one for aerobic organisms, another for anaerobic. Now, how will you do fluid resuscitation in a case of maternal sepsis? The principle is it needs aggressive volume replacement. 30 ml per kg IV crystalloid is to be provided in first 3 hours. Ringer lactate is the crystalloid of choice. 1 liter is given as a bolus in first hour. Remaining the volume is to be given as repeat boluses. It improves cardiac output and oxygen delivery to the tissues. As we have already seen, tissue hypoperfusion leads to septic shock and it precedes hypotension. But unfortunately, the effect of this bolus administration of IV fluids remains only for 1 hour. It is transient. Now, once you provide this, after 3 hours of the volume replacement, fluid management is to be done as per blood pressure, urine output, and lactate level so that there should not be under perfusion or over perfusion. By 72 hours, restricted fluids are recommended where you give input should be equal to urine output, or in wherever you suspect that patient might go for a pulmonary edema also. In such cases input can be even slightly less as compared to urine output. What is the antibiotic policy in a case of maternal sepsis? Antibiotics are to be initiated at the earliest after taking culture samples. That means you need to take the appropriate cultures as per the patient's condition, vaginal culture, or you want to take cervical swab for culture, or if you are suspecting that there is a wound infection, then from the wound itself, episiotomy wound, cesarean section wound, we have to take samples for culture. Initially, we give IV broad spectrum antibiotics, which are empirical. And once we get the culture report, then targeted intravenous antibiotics are to be given. Examples of broad spectrum are amoxicillin clavulanic acid combination along with gentamicin. This is for gram positive, this is for gram negative, gentamicin, and metronidazole for anaerobes, or we can even give clindamycin or piperacillin tazobactam along with clindamycin, or we can start carbapenems, which are uh, very effective against both most of the gram positive as well as negative organisms. And if we are suspecting methicillin resistant staph aureus infection, vancomycin should be initiated. Surgical interventions which are necessary in a case of maternal sepsis are, now if patient is pregnant and baby is still inside, then timely induction of labor is very, termination of pregnancy is very important, either induction of labor or by cesarean section as per the condition of the woman and the baby. But termination of pregnancy improves the prognosis in many cases. Then evacuation in septic abortion. Retained placental pieces are to be removed in case of a puerperal sepsis. Debridement helps to improve the prognosis in necrotizing fasciitis. Drainage of abscess. Rarely hysterectomy is necessary for puerperal sepsis. I have not seen a need for hysterectomy for a puerperal sepsis, though I have seen a need for hysterectomy in a case of severe septic abortion. That I have seen. Now, what is the cause of septic shock? Septic shock is either it is because of tissue hypoperfusion and or hypotension. We have already seen hypoperfusion precedes hypotension. What is happening in septic shock is there is redistribution of intravascular circulation because of capillary leakage. There is a damage to the vessel wall, capillary leakage, and that leads to hypovolemia. Peripheral vasodilatation is also there with the inflammatory cascade, which is triggered by the presence of infection. Cytokines are released, and there is a peripheral vasodilatation where we find the patient having a warm and flush skin, and then it is called as a warm phase of septic shock. Myocardial depression is also one of the factor which leads to this hypoperfusion or hypotension leading to septic shock. So there is a combination of all these: hypovolemia, peripheral vasodilatation, myocardial depression. All this together also can be functioning in the same patient, leading to septic shock. Whenever there is a peripheral vasoconstriction, it indicates late stage of the septic shock, and that is called as a cold phase, which is associated with bad prognosis. So how do we manage septic shock? Patient needs to be shifted to ICU at the earliest. Vasopressors are to be started after 1 hour of fluid resuscitation if there is a persistence of hypotension. Early initiation of vasopressor improves the prognosis. Norepinephrine is the first drug of choice, and our goal of giving vasopressor is to maintain mean arterial pressure greater than 65 millimeters of mercury. That ensures that there is a adequate tissue perfusion. Steroids can be given if, in spite of giving vasopressors, patient remains in hypotension. Then low dose steroids are can be given to. In some studies show that there might be improvement in prognosis. Then, as per the requirement of a case, blood components and correction of coagulopathy to be done by giving blood components. Ventilatory support is necessary in some patients with mechanical support also if there is a lung damage, and multidisciplinary approach saves the life of a woman in a case of septic shock. Now this is practice question I am giving because it is I thought that it is a theoretical topic, but it is not theoretical. Believe me, it is so important in clinical practice, and so many times as obstetricians we do fumble for in early detection of maternal sepsis. And by the time patient goes for a septic shock, it is already too late. That time, even if you involve infection uh, medicine specialist, then also so many times there is a irreversible progress, and we are likely to lose a patient, and that hurts us a lot. Every maternal mortality you carry lifelong, we have those memories and we carry it with us. Whenever there is a maternal mortality, we always go back to that scenario and think what went wrong, whether it was preventable. And one of such is a maternal mortality because of sepsis. So practice question case scenario is 24-year-old primigravida with 34 weeks pregnancy comes to outpatient department with history of fever, pain during micturition, frequency of micturition. A very common scenario. We see so many patients in pregnancy having such type of presentation. She has fever 100 degrees Fahrenheit with pulse rate of 90 per minute. Blood pressure is 120 by 80. Respiratory rate is 18 per minute. She is well oriented. Her CBC report is normal. Now you tell me whether she is a case of maternal sepsis. So I hope that by this time you are able to apply SIRS criteria as well as Q SOFA criteria and confidently to say whether it is a case of maternal sepsis. Now she has definitely she has infection. She has difficulty during micturition, frequency of micturition. She has fever. That means urinary tract infection is likely to be present. We do know that she has infection. Now the main question is whether there is an underlying organ dysfunction to call it as a case of maternal sepsis. So it is not a case of maternal sepsis because patient, though she has infection, urinary tract infection, by applying Q-SOFA as well as SIRS criteria, we can rule out maternal sepsis. Now this patient is given oral antibiotics after sending urine for culture and sensitivity, and she goes home and she comes 1 week later. Unfortunately, now she is coming with preterm pre-labor rupture of membranes of 48 hours duration. She stayed at home for 48 hours in spite of having rupture of membranes, and now she is presenting so late with a duration of rupture of membranes of already 48 hours. Her pulse rate is 100 per minute. She has fever 102 degrees Fahrenheit, but her mental status is normal. She is alert. Respiratory rate is 24 per minute. Blood pressure is 120 by 80 mmHg and CBC is within normal limits. So what is our diagnosis now? Now, if you apply Q-SOFA criteria, I think that in the Q-SOFA, only one she is fulfilling is respiratory rate greater than 24, 22. Otherwise, her mental status is normal, her blood pressure is normal. So Q-SOFA says she is not a case of maternal sepsis yet. If you apply SIRS criteria, you will find that pulse rate is more. She has fever also, and respiratory rate is also greater. So though WBC count is normal, all these three are positive, and by SIRS, she becomes a case of maternal sepsis. So as per SIRS criteria, it is a case of maternal sepsis with increase in temperature, pulse and respiration. Q so far is normal because it is fulfilling only one criteria, respiratory rate greater than 22, greater than or equal to 22. But her mental status is normal and her blood pressure is, she is not having hypotension. So by Q so far, it says that she only has infection. Now this patient needs hospitalization. She was advised hospitalization, but patient was not willing that time. She wanted to get admitted to another facility and she went. She was not willing and she went home. But 3 days later, same patient came with not taking any medical care in between. Now, especially in developing countries and countries like India, this scenario is very common. You advise hospitalization, patients, unfortunately, so many times are not having any family support. There are so many problems, personal issues, and though patient needs hospitalization, she is not able to get admitted so many times, unfortunately. So same happened here. Now she has uterine tenderness because her rupture of membranes duration is now increasing so fast. 3 days for initial 2 days, and now another 3 days. She has uterine tenderness. That means chorioamnionitis is taking place. Respiratory rate has increased to 28 with a fall in blood pressure. Systolic blood pressure only 90 mmHg. So, what is your opinion now? She had by Q so far now blood pressure is less than 100, systolic blood pressure. Respiratory rate is 28. That means she is definitely now a case of maternal sepsis by Q SOFA also. Maternal sepsis as per Q SOFA, and she needs hospitalization. Once she is hospitalized, we need to initiate sepsis protocol and sepsis bundle. In spite of IV ringer lactate 1 liter in first hour, her systolic blood pressure remained 90 systolic, but her mental status with her altered mental status. She was now having a confused response to the verbal command, and her Glasgow Coma scale was less than 15. So altered mental status is there. Blood pressure is remaining persistently 90 systolic in spite of bolus crystalloid aggressive volume fluid replacement. So what is your diagnosis now? Fall in blood pressure, altered mental status is also there. So unfortunately, she has progressed to septic shock because of the neglect of her PPRIM for a very long time. She now her we can assume that she has severe chorioamnionitis. So aggressive management is necessary in this case. ICU admission with the four-prong approach, fluids, cultures, ongoing assessment with laboratories and SOFA, antibiotics, and as already with the IV fluids, she has persistence of hypotension. She needs vasopressors also. SOFA, vaginal and urine culture, blood cultures are to be sent. Imaging is to be done, especially obstetric imaging for the condition of the baby, and timely pregnancy termination can save this woman. And if she needs a multidisciplinary approach. So you can see that how a disease is going from a stage of infection to sepsis and from sepsis to septic shock if the woman remains neglected for in the precious first initial 2 to 3 days of the sepsis. Important change in concept in our concept is older terminologies where First, infection sets in, then there is a systemic inflammatory response syndrome, then sepsis develops, then a stage of severe sepsis and septic shock. That was the previous old terminology, which has been replaced now by infection, sepsis, and septic shock. As per Q SOFA, criteria are getting fulfilled, then sepsis, and by SOFA criteria, we know the prognosis of a case and we diagnose septic shock on the basis of rising lactate or fall in BP. That is another important change in concept. Previously, only fall in blood pressure was called as a case of septic shock. Now we know that in a normotensive woman also, rising level of serum lactate is sufficient to diagnose it as a case of septic shock. And this shows a rising mortality also as the disease progresses from a stage of infection to sepsis and from sepsis to septic shock. To summarize, with each case of infection, obstetrician should be sepsis vigilant. Institutional sepsis protocols and sepsis bundle reduces mortality. Aggressive fluid therapy improves outcome. Serum lactate monitoring reduces mortality. This is most important emerging biomarker of the sepsis is serum lactate. Every 4 to 6 hours it should be monitored. Timely pregnancy termination or surgical intervention can it saves the life and it improves the prognosis in the case of maternal sepsis. And what is most important is having a multidisciplinary approach. Thank you so much. I have taken help of RCOG guideline, Green Cup guideline 2024 for diagnosis and management of maternal sepsis, American Association of Family uh, guideline 2020. Family Physician, American Association of Family Physician Guideline 2020 and Williams 2019. Thank you once again.